Great. I think we can get started. Welcome, everyone. Thank you for joining us for this third installment of the TORS webinar series. It's my pleasure to introduce a really awesome panel today. This panel is going to be moderated by myself, Uma Devorian from the University of Pittsburgh Medical Center, and Dr. Rani Meyer from the University of Maryland Medical Center. And we have three outstanding panelists that we're going to sort of pick their brains about some of the decision-making in the management of oropharyngeal cancer, especially as it pertains to transoral robotic surgery. We have Dr. Robert Ferris from the University of Pittsburgh Medical Center, my friend and colleague, Dr. Daniel Ma from the Mayo Clinic, a radiation oncologist, and Dr. David Palma from London Health Sciences Center, also a radiation oncologist who has a terrific expertise in the management of these patients. So each webinar is going to be a little different as you go through the series. This one we decided to focus on current data and future trends and the data that we use to guide our decision-making and how to manage patients with oropharyngeal cancer. So we're going to start off, because it's so data-driven, by presenting a few slides to talk about the problem at hand, and then we'll switch to the cases. So I'm going to start off by giving a few slides at the beginning about surgical therapy for oropharyngeal cancer and de-escalation and some of the current concepts. Dr. Meyer will follow up on that with some additional slides talking about some of the other data that you guys will maybe hear being quoted by our panelists. So we thought it'd be good for you actually to see the data so that you could then understand what's being quoted and what we're referencing. So with that said, I'm going to start off with this panel. I'm sharing some slides here. Hopefully you guys will see this. So evidence-based decision-making in TORS is the title. Our panelists have already been introduced. So we know that oropharyngeal cancer really comes in two different flavors now. Ones that are associated with heavy tobacco and alcohol consumption, which tends to be carcinogen-driven malignancies. And here's a picture of one of our wonderful patients from Pittsburgh. I think I got this slide from Dr. Ferris. He's probably one of his patients. And on the right of the screen, you see the human papillomavirus, and therefore the disease that is associated with HPV and the concomitant genotype that portends this, including increased expression of P16. This is some very old but very important data from Anil Chaturvedi. So Anil has published extensively on this topic over the years and was one of the first people to describe this increasing incidence of human papillomavirus-associated oropharyngeal cancer. And in fact, by this time, the curves have actually crossed, and oropharyngeal cancer, at least HPV-associated oropharyngeal cancer, has overtaken cervical cancer in the United States and most of North America. So this is probably now one of the most common virally driven cancers in the country. This is important because we know that people with HPV-associated oropharyngeal cancer enjoy better survival. So here's some data from Carol Fakhri showing that there's an approximately 18-fold increase in the frequency of 5-year survivors, especially those that are suffering from oropharyngeal cancer. So while we are really careful and we want to be considerate of maintaining oncologic survival for these patients, I think it's really important to think about the quality of life for these long-term survivors as well. And that's where you'll hear a lot of these concepts as we bring these out in the panel, talking about QOL. It's not because we don't care about the survival for these patients, but we also want to remember to think about the QOL for these long-term survivors. Now moving on to some of the techniques that we're going to be discussing. So this is a standard radical open surgery that we would perform for a patient with oropharyngeal cancer. This is one of my patients in fellowship from MD Anderson. This slide was courtesy of Dr. Jeff Myers. So we can see that this is a pretty gruesome operation with significant morbidity, tracheostomy, long-term stay in the hospital, etc. And so this sort of surgery was really quite ominous for these patients, and I think many of us shied away from doing the surgery for quite a long period of time, especially with the advent of non-surgical therapies that proved to be equally beneficial in the management of these patients. But having once again talked about the quality of life of these long-term survivors, Michael Douglas here, who was the speaker at the Head and Neck Society International meeting about two meetings ago, gave his story of going through the process of being diagnosed and treated for HPV positive cancers. And so we continue to think about how to maintain the functional outcomes for people that tend to be relatively high performing individuals who are now afflicted with this disease. So how do we reduce the morbidity while maintaining the oncologic outcomes? And this has really been a main aspect of care. Another really important thing to consider is that because the survival for these patients is so good, we have actually adopted a new staging system for these patients, which I know many of you are aware of. And this was work that was, I would say, championed by Brian O'Sullivan from Toronto, as well as Bruce Hoey, thinking about the staging of these patients and recognizing that the 7th edition staging was not necessarily reflective of the survival benefit that these patients enjoyed from HPV-associated cancers. So I'm not going into the details of this. I think we can all look at the staging manuals. But what I wanted to focus on was that there are 2 separate staging criteria for this, especially when we really delve into the 8th edition. There's a clinical stage, a clinical end stage specifically, and then a pathologic end stage. And so here you can see that in the clinical end stage, there is no more N2A, N2B, N2C, but we have N2 disease, which encompasses contralateral, bilateral nodes, and then large nodes, larger than 6 centimeters, becomes N3. Similarly, in the pathologic criteria, we now start talking about the number of nodes that are positive, 4 or fewer nodes, 4 or more nodes, upstaging patients to N2. And this is important as we now start thinking about how to interpret some of the prospective trials that are going to be read out, like Pathos and ECOG 3311, which started in the era of the 7th edition. So we just have to kind of keep that in mind. And so for the trainees in the audience, I want you to be cognizant of this as you interpret the data and as you hear about these data. But what's particularly important is when we look at these staging schema, the overall stage, the TNN stage when combined, a T1 N1 tumor in the 7th edition would have been staged as a stage 3. Whereas now a T1N1 or a T2N1 becomes a stage 1. And so these patients, when we see them, we're telling them, oh, you're stage 1 cancer. Whereas in the old days, they would have been a stage 3 cancer. And here's some really nice data from John Kramer, a former fellow of ours at Pittsburgh, who's now in faculty position in Detroit, who showed that by the new 8th edition, it's no longer really new, by the current, I should say, 8th edition staging, the proportion of patients with stage 1 disease increased dramatically from 3.2% to 64%. So we're going to see a lot more people with stage 1 disease, which then leads these patients to, at least in my clinic, ask me the question, well, doc, if I'm a stage 1, why do I need chemotherapy and radiation? Why do I need such what seems to be aggressive therapy while being a stage 1 patient? And so we're going to talk a little bit about these sort of concepts, but for the trainees in the audience and just for everyone, you should remember that while we stage on the 8th edition, we treat based on the 7th edition. We have not changed our treatment paradigms based on this new staging, and this is a really important point that I want all the trainees to remember. So while we talk about future trends and sort of more pie in the sky ideas, the here and now is that the 7th edition is the king, and that's how we currently treat patients. Despite that, treatment carries with it a significant toxicity profile, and here's some data from Mitch MacDay, who showed that there was a fairly high rate of severe late toxicity with definitive chemoradiotherapy protocols based on subset analyses from the trials that I've listed here. So jumping into it, what's on the horizon? Well, we want to maintain outcomes. We want to improve quality of life. So we therefore want to appropriately, and I stress this word, appropriately de-escalate care for the right patient. I don't think that everybody should be de-escalated, but we're going to talk about that also. Who would we de-escalate? What would we do for different patients? So there are a couple ways to think about this de-escalation. One is with surgery and risk-based adjuvant therapy. So there are several trials that are ongoing and some have been completed, looking at using surgery to hopefully reduce adjuvant need for chemotherapy or chemoradiotherapy. And so the question here is, can minimally invasive surgery de-intensify treatment for these patients? And then there are also, ways to de-escalate therapy from a definitive non-surgical standpoint. And there are several excellent trials that have been conducted and are ongoing that have asked this question, including ECOG 1308, which is induction therapy, HM002, which was a randomization to CIS versus CIS plus RT, and we'll talk a little bit about that as well. So why surgery, and why do we think that this is even meaningful or useful? Very provocative data, really old data from 2006 from Lisa Lasitra in Milan. So Lisa looked at a cohort of patients that were treated at the Instituto Tumore in Milan with HPV positive disease or HPV negative disease. These are all oropharyngeal cancer patients. This was 2006, so this is retrospective analysis. So this is before we had the Bernier and Cooper data to impact the use of chemotherapy for these patients. So that's why all patients were treated with radiotherapy alone. And she broke these patients down to 4 groups, HPV positive or negative, and those that had low volume disease and did not need radiation versus those that had high volume disease and needed radiation. And again, with a fairly long follow-up here of up to 8 years, we see a really spectacular outcome for those patients with HPV positive disease that did not need any adjuvant therapy. So therefore, low volume, presumably T1, T2, N0 to N1 type patients. So this sort of is a very interesting concept for us to think about. Here's some data from MD Anderson, courtesy of Neil Gross, where they looked at single modality therapy and the use of gastrostomy tubes in patients, and this is based on a prospective registry at the institution. And they found that gastrostomy tube rates were quite different between patients that were treated with radiotherapy alone versus those that were treated with surgery alone. Again, provocative data, but not a prospective trial by any means, just a registry. But this registry also, in their experience, seemed to favor robotic surgery alone, or surgical resection alone, versus a non-surgical therapy in patients that were treated with TORS alone or had TORS plus adjuvant therapy. And this is again based on this prospective registry. So how we interpret these sort of provocative data is what we're going to put to the panel. That's what we're going to sort of pick their brain, how they interpret these data and how they move these into clinical practice. So a host of trials are currently ongoing for surgical de-intensification, some of which are completed, such as ECOG 3311. Pathos is ongoing, and Best of, which is led by Krishna Simon, and EORTC is ongoing, which seeks to randomize to surgery versus non-surgical therapy for low-risk patients. Here's the ECOG 3311 trial schema. So this is the one that was presented at ASCO last year, and an update was presented at ASCO this year by Dr. Ferris. So basically patients with T1 to T2, N1 to N2B, it's once again 7th edition staging, who underwent transoral surgery. I wrote here TORS, but really it's any approach, transoral surgery. And then those that were low risk were assigned to observation. So there was basically pathology-based radiotherapy that was given to these patients. Patients that were in what we consider the intermediate risk group, that is clear or close margins, but had a small amount of extracapsular extension, had 2 to 4 lymph nodes, were randomized, and PNI or LVI also, were randomized to 50 versus 60 gray radiation. Patients with high-risk disease, as gross positive margins, gross extracapsular extension, or a large number of lymph nodes positive, greater than 5, were given cisplatin at 40 per meter squared with IMRT. And of course, the 2-year progression-free survival was the initial sort of endpoint of this study. So here's the design, once again, in slide format. So again, thank you, Dr. Ferris, for sharing these with us. And again, here are the sort of percentages of patients that were enrolled into each group. So T1 to T2, N1 to N2B, 11% only, basically 10% were enrolled into arm A, and 58% were randomized. Now, when we look at the Kappa Meyer curves, these are 3-year progression-free survival estimates now presented this year at ASCO. We see that arm B and D are basically equivalent, so there's non-inferiority there. And arm D, however, seems to have a bit of a separation of the curve. This is progression-free survival, but overall survival seems excellent for all patients, although there still is a decrement in arm D. This is the arm that presumably had extracapsular extension. Now, when we look at the quality of life scores, there were 2 metrics that were presented: MDADI, the MD Anderson Dysphagia Inventory, and the FACT H&N. which are the two metrics that we use, we see that at least for MDADI scores, the yellow line here is arm D, always seems to be inferior at 2 years versus the others. But arm B and C seem to be sort of on top of each other. And of course, the no adjuvant therapy arm seem to do better. In FACT H&N, there seems to be a tendency for them all to converge a couple of years after therapy. So there are some additional trials, as I said, quality led by Christian Buchwald from Copenhagen and Vestavra by Christian Simone that we'll get to. But what I found very interesting is now this concept of de-escalation in the post-operative setting. So here's some slides that were generously shared by Dr. Ma, and hopefully he'll elaborate on this a little bit more, during the panel. Patients were treated with transoral surgery and then broken into two cohorts, cohort A versus cohort B. Cohort B had had any extracapsular extension noted. These patients were treated with paclitaxel and 36 gray in BID fractionation, so basically, very short duration of treatment. Cohort A had 30 in 1.5 gray BID, again with paclitaxel, and he showed excellent outcomes of these patients, and this paper was published in JCO. This is again the schema for these patients. If I understand correctly, so these are all patients that had less than 10 pack year smoking history. So these were, and this is kind of a red herring. So we're going to really hopefully delve into this in the panel, but really impressive survival, really impressive data from this sort of de-escalation concept. And then there's now a prospective trial that was completed accrual. I was just informed, which will be presented, I believe, at ASTRO this year, where there's again a randomization to Taxol with radiotherapy, including Taxol versus standard of care, which is for patients with high risk E&E present with 60 gray and cisplatin. So this will also be very exciting information to sort of look at these two regimens head to head in the adjuvant setting. So again, exciting data. We look forward to hearing more about this. And of course, there's another concept now of sparing the operative bed with using protons, but there are other concepts like this, which is a void paper from Penn. I didn't have time to present all the data, but there's another concept of not just changing the how much radiation you give, but what structures get radiated. Now, what is the radiotherapeutic field, not just the dose that's given. And this is very exciting data as well. And we hopefully we can sort of get our audience, our panelists to tell us a little bit what they think. So I'm going to stop here, and we can I'll hand off to Dr. Mehra to.
Thank you, Dr. Davari. Perhaps in the interest of time, should we just keep the same slide set?
Yes, maybe that would be better.
Yeah, that'll just be easier. So thank you everybody for joining us today. I wanted to pick up from Dr. Davari's great and comprehensive summary about surgical and adjuvant data, and talk a little bit about non-surgical management, and mainly because in the context of multidisciplinary care, I'm sure in many of our practices, when we are initially meeting a patient who has oropharyngeal cancer, that's the first decision point we have, whether to proceed with surgical or non-surgical. And so we need an understanding of both approaches in order to make those decisions. And many of us focus on functional outcomes, on what the perhaps adjuvant therapy would be if a patient proceeded with surgery first in some of that initial decision making. There have been, as was just presented, numerous attempts to look at de-intensification in the surgical setting, and this has been done in the non-surgical approach as well. And different questions that have been studied have included the role of withdrawing systemic therapy from the chemoradiation regimen and just doing radiation alone, considering cetuximab instead of platinum, and considering lower radiation doses. So if you go to the next slide.
Sorry, there we go.
Okay. So first I wanted to just briefly present the order data that was published by Dr. Nichols and Dr. De Palma. And in this trial, patients who had T1 or T2 N0, N2 with maximum nodal size less than or equal to 4 centimeters oropharyngeal cancer were randomized to either radiation therapy with concurrent chemotherapy in node-positive patients, or with TORS plus neck dissection with adjuvant therapy, depending on the pathologic findings. Next. So these treatment assignments, this is the consort diagram, which shows that 68 patients were enrolled and assigned, 34 were allocated to radiation, 34 were allocated to TORS. A couple patients were lost to follow-up, and an equal number of patients were assigned in either group. So in general, the primary endpoint of the study was the quality of life in 1 year post-treatment. And I think somewhat, maybe surprisingly, or depending on who you talk to, the functional outcomes, especially to swallowing, seem to favor the group that received radiation therapy. I think this is something we'll discuss more in our panel discussions, and hopefully we can delve more into the data in that space. I think we also appreciate that there are different toxicity profiles, and not surprisingly, less neutropenia in the patients who received surgery, less tinnitus in that group as well. And so obviously there's the potential toxicities that a patient may undergo is an important decision, and there's no clear right or wrong without taking patient characteristics into account. Next. And this just shows the overall survival and progression-free survival, which, as you can see, was very good in both groups. And then the Kappa Meyer curves on the bottom illustrate the difference that we know exists between P16 positive and P16 negative disease. So ECOG 1308 was a single-arm phase 2 study, which was looking at the role of chemo selection with, at the time, the regimen of platinum, paclitaxel, and cetuximab was used. And patients who had a complete clinical response went on to receive a lower dose of IMRT 54 gray with cetuximab. And this was conducted before the RTG 1016 was presented. Those who did not have a complete response went on to receive full dose radiation with cetuximab. And the rationale for this approach was to use chemo selection to find the group of patients who would still have a good survival outcome with the lower dose radiation therapy. As was mentioned, this did show 2-year progression-free survival of 80%, but the best group of patients who had the best outcomes were those who at the time had the favorable clinical characteristics with regards to TNN stage and no smoking, less than 10-pack-year smoking history. NRG HN02 has also looked at the question of radiation with cisplatin versus radiation alone. And you can see here, arm 1 received 60 gray of radiation in 6 weeks with weekly cisplatin, arm 2 was 60 gray of radiation for 5 weeks without the cisplatin. And this was also a favorable group of patients who were selected. Next.
Oh, there we go.
So obviously it's very important on the functional outcomes, and for us also the risk of dysphagia and the need for feeding tube placement. The patients who had chemotherapy with the radiation did seem to need feeding tubes more during treatment, but at 1 year and 2 year, there didn't really seem to be that much difference. And the primary endpoint was the PFS. So the 2-year PFS estimate for IMRT with chemotherapy was 90.5%, which rejected the null hypothesis that was laid out in this trial. However, the 2-year progression-free survival estimate for the IMRT arm without the chemotherapy was 87.6%. And so that arm did not meet its endpoint that was pre-specified on the study. And I think this is something that, you know, we're still considering then in our further clinical trial questions today. Sorry, next. And then recently, Nancy Lee and her colleagues at Memorial had published this, I think, very provocative study looking at the role of, as they put it, precision radiotherapy using biomarker guidance in order to select patients who could be de-escalated to a dose of 30 gray. Next, the schema for this study kind of illustrates the course of patients at the bottom, in which patients received imaging in order to assess for hypoxia at baseline. Those that had negative results for hypoxia were selected to be de-intensified at the onset. Those who were positive were then went on to potentially receive full dose radiation, but they did have another assessment in the middle of treatment, and then those who were negative for hypoxia at that time were then moved into the de-intensification arm. At the end of the study, all the de-intensified patients had a neck dissection to assess for pathologic response, and all patients received chemotherapy, either cisplatin at bolus dosing or carboplatin and 5-fluorouracil. 90% were non-smokers. Amongst the de-escalated patients, there was no need for feeding tubes, and their dysphagia and dermatitis was minimized. The efficacy outcomes were actually positive, although it was a small study with 19 patients enrolled, and the 2-year local regional control progression-free survival and overall survival was 94%, 89%, and 94% respectively. They did look at biomarkers, genomic biomarkers, especially in the patients who were responders, and found an increased double-strand repair defects deficiency in that population of patients. So certainly a provocative study. And so I think with that, we're ready to move on to our cases.
Yes, so I'm going to hand this on, and thank you, Dan Pinero, for pointing out a typo in my slide. It was true that there was the HPV positive or P16 positive oropharynx, if operated, is only PN2, supposed to say CN3 as a contrast. So I apologize for that typo. So we'll say CN3 versus PN2, which is that there is no N3 in that population. So let's jump into the panel. So let's start with case 1. Great. So we have a 55-year-old female with adenoaphasia, several month history of adenoaphasia. She's a lifelong smoker, is about a 40-pack year smoker. She has no trismus and no obvious adenopathy on physical exam. So next slide. And so, in the interest of time, the biopsy confirms squamous cell carcinoma. Next. And the P16 immunohistochemical stain is diffusely positive. So again, I know that a lot of people have talked about this in other webinars, but I just thought I'd start from the top and kind of work our way down to ask Dr. Meyer, what's your imaging of choice? I know you're a moderator, but I thought I'd just get everyone's input on this for these kind of patients, P16 positive oropharyngeal cancer.
So, I guess I certainly would want cross-sectional imaging. I'm sure my surgery colleagues would want to have imaging that defines the anatomy well. So I'll I guess, start with CAT scan imaging, but I'm happy to hear what the rest of the panel said.
Yeah. Dr. Ma?
We standardly start with CT of the neck with contrast. Obviously we'd be looking at the endoscopic findings as well. If there's evidence of an endophytic tumor rather than an exophytic tumor, we would go ahead and get a neck MRI to try to see what the submucosal extent of disease would be. I don't know what the nodal status is based upon this physical exam, but depending upon that, we would triage between having a PET CT versus a CT chest.
It's at N0. She's an N0.
She's N0 clinically, right?
N0 okay. And then Bob, I think I know what you're going to say.
Yeah, agree with CT neck with contrast.
Right. And Dr. Palma, do you guys?
Yeah, absolutely. And the only other reason we get MR is in people getting radiation for delineation purposes, if there's any amalgam that can be interfering with the delineation of the primary tumor. So I'd say about half of our patients, if they do go for radiation, are getting MR as part of their simulation process.
Right. So nobody starts off with a PET CT scan right off the bat. It sounds like everybody's going with a contrast enhanced CT. Good. Next slide, please. So this lady actually came to us with a PET CT scan, which is not uncommon. So here we see just a couple of representative cuts, lesion of the glossotonsillar sulcus, and and I can tell you that on physical exam, this was really quite this is hard to feel, but somewhat palpable. So since we're coming up with this, or you've been given this PET scan, Dr. Ma, do you do anything different? I mean, do you go backwards? Do you get a CT or MR in these kind of cases?
Definitely we still usually get a CT neck in the setting of trying to delineate out what the vascular structures would be in relation to nodal disease. But in this instance where it's clinical N0 disease, endoscopic examination to look at, exophytic versus endophytic nature of the tumor and things like that. I'm not sure
You
what
wouldn't
else a
necessarily
CT.
go ahead.
Exactly, yeah.
Got it. Yeah, Dr. Palma, would you guys go backwards and get it?
It's pretty rare in Canada that you'd have the PET before the CT, so it's almost never happened. But nonetheless, we probably would if the patient's not going for radiation. If they are going for radiation, we're going to be getting a contrast scan as part of simulation anyway. So with the PET, we'd probably be okay.
Got it. And Dr. Ferris, we see these not infrequently. What's your practice in this?
I absolutely get a contrasted CT. I think it's more useful. That this particular PET looks reasonably confined and localized, but I'd certainly want to see a contrasted CT. And to some degree, as Dr. DeVore is aware, it's a collaboration with our radiologist and what they prefer as well. But surgical planning, I think contrasted CT is helpful.
Yeah, so I think from the audience perspective, I think what you're hearing us say is, PET scans are nice, but good high resolution cross-sectional imaging of the area of interest is really critical if you're going to be planning some surgical intervention. Next slide, please. And so here's a sort of a polling question for the for the audience. Given this, I'm just going to briefly summarize. We think this is a T1 N0. How would you treat this patient? And here are the choices: surgical therapy, XRT alone, radiation therapy alone, platinum with radiotherapy, or something else. And a few seconds to get people to vote.
You have any music to play?
I know, I feel like we should have the Jeopardy music or something, right?
We missed that.
It is true. Okay, so not everybody. Okay, all right, so it looks like we have an audience that is really pushing a TORS here. Okay, so let's go on to the next slide. Can everybody see the results? I think. Okay, great. So these are the results. I think, do I have to hit share? I think I have to hit share results. And then can everybody see those results? Okay, great. So, so again, one of the but let's start from the top. So Dr. Ma, what would your institution's what your institution's experience be? What's your protocol for managing these patients?
So assuming it's an exophytic tumor without significant encroachment along the soft palate, which it looks like it's a tonsil tumor, is that correct?
Correct. It's the glossotonsillar sulcus. So it involves
glossotonsillar sulcus, doesn't really involve soft palate, doesn't really involve any other structures. Exophytic tumor, we would standardly go with TORS and evaluation for adjuvant treatment afterwards. There's a reasonable chance this patient may not require any adjuvant therapy.
Fair enough. Okay. Dr. Ferris?
I agree with Dr. Ma. That's what our institutional policy would tend to be. And to be honest, it's sort of transferred or translated from other sites in the head and neck. If we thought we could do an organ sparing functional surgery, number one, for good function and reduced modality therapy, but also for true biological staging. And I think, this patient does have the possibility of having occult metastatic nodes. And so it's important to know the actual pathologic stage.
Dr. Palma.
Well, I guess I get to weigh in with a contrarian view of
Yes.
the 9%. So I think the first thing I'd acknowledge is regardless of what we do, the PFS here is going to be excellent, even with smoking. And smoking, of course, is a bad prognostic factor, but whether it differentially impacts the choice of first treatment probably is unknown and is certainly debatable. And so if we accept the fact that the PFS is going to be probably no different between a primary radiation and a primary surgical approach, something that'll probably be never proven in our lifetimes, is to look at what's going to be the least toxicity. So if we knew that they were going to get TORS alone and nothing adjuvantly, then we saw Dr. Ferris's trial, those MD-ADI scores were probably the best I've ever seen, TORS alone. But when you start getting into TORS plus the adjuvant radiation, the MD-ADI scores are down. They're down often in the high 70s, maybe 80. In our orator trial, it was 80 in the arms B and C in E3311, they were in the high 70s. And in the radiation trials, we're seeing them up in the 80s, right? So with Sue Yam's trial, HN2 in the IMRT arm, 86 or 85, orator the same way. So I think, in many different fields of oncology, we deal with a situation where we'll never know for sure what, surgery is better, radiation's better. And we all, of course, have our intrinsic biases. But I think in this case, the patient needs to be offered a choice, right? With the pros and cons, acknowledging the fact also that the only randomized trial that's compared the two, orator, has sort of upended what we thought about TORS having less toxicity. So I think this, we would do XRT alone. If you were to be a purist, you'd say the randomized evidence, although small, supports that. But I think not giving the patient a choice is a bit, I would say, perhaps paternalistic.
Yeah, I just want to chime in there. I think giving the patient a choice, and Dr. Palmer's right, that I neglected to sort of put that out there. I think there is, another individual in the discussion besides the three modalities in the tumor board, and particularly for HPV positive disease. So I certainly acknowledge that, but I would really caution us on 2 points. Number one, comparing scores across vastly different trials where there is selection at different centers. If you look at the pathologic staging that ended up from 3311, dramatically different than the surgical arm of orator in terms of the group that got surgery alone, 33, 35% versus 10 or 11%. So a very early stage group. 23% got surgery plus chemo RT versus 30+%. So a higher risk group was operated on just based on trial selection. So that's why we don't compare trials across different centers. And also, I just think we want to see more than 1 year swallowing data from orator, and maybe that's coming.
Yeah, those are excellent points. And I think there is the weakness to the cross trial comparison. I think my point I could perhaps better define is that, when with the advent of TORS about 10 years ago, the paradigm that came across from the US, and we were very excited to see this, that TORS is going to be a lot better. TORS is going to be a lot better. The swallowing is going to be better. And it was compared with these G-tube rates of 48% and Mitch McTay's data, which can include T4 patients where the base of tongue is gone after the tumor is gone, so they can't swallow. And now I think it's fair to say that the evidence supports at least equality between number one and number two. Of course, there's no non-inferiority study, but I think the idea of 10 years ago that TORS is going to be clearly better than radiation. One thing that we found on orator is that you'd see these patients in your clinic, you don't really notice before the T1, T2, and zeros who are sailing through their radiation. They do fantastically, right? And so I think maybe just to reset a little bit of expectations around, it's likely that, as we heard in the introduction, it's probably an idea more of different toxicities and which toxicities are most acceptable to the patient rather than superiority.
Yeah. So,
Dr. De Palma, with the primary site based on order, does the primary site of the tumor influence what you believe the functional outcome would be?
Yeah, and to be honest, I would defer a bit to Dr. Ferris on this in his TORS experience. In the number of patients that we had, we didn't see the base of tongue swallowing scores were worse down the road than the tonsillar ones. We did have with the tonsils, we did find this trismus. I guess it might be related to scarring in the operative bed. I'm not totally sure, but I would expect that the tonsillar patients would do better. GT sulcus is sort of in between. So I would be interested in hearing from Dr. Ferris about what his thoughts are, base of tongue, GT sulcus, tonsil in terms of function.
We have only done very top line. Our QOL co-chairs are analyzing the data, so I don't yet have that, unfortunately. So apologies for that.
So if I
No,
may
I
ask,
think one of the takeaway messages I got from Order, and by the way, I think, you know, it's a fantastic trial. It's one of those trials that is very difficult to pull off in the United States. So hats off to you guys for doing the trial. But one of the takeaway messages I got from it is patient selection is important, right? It's hard to walk away with a blanket statement saying, you know, we need to moderate expectation for TORS, or what should we be looking at swallowing function after radiation therapy, when we're talking about vastly, even within T1 tonsils, right? We can be talking about an exophytic tumor that you just whack off and it's a little stalk and there's very little disruption of the underlying normal anatomy, versus one that's deep in endophytic that might lead to trismus afterwards. This goes back to Bob's point as well about multi-institutional trials. And, you know, one takeaway message I got is, you know what, we're going to have this discussion later on, I believe, Uma, about surgical margins and how they affect things and things like that. There's vastly different expectations of what a negative margin would be at one institution versus another. And you can easily imagine a tonsil tumor that has a larger margin that requires more of the soft palate resected, leading to poorer swallowing outcome, versus you know, one with a tighter margin placed because there's real-time pathology available at the time of surgery. So I would caution that it's a very large heterogeneous pool when we talk about TORS. There's the aspect of patient selection and appropriate patient selection that needs to be discussed. And then there's a whole nother bag of worms of how is the TORS being performed? What is the real-time pathology that's associated with it as well?
thank you, Dr. Mal, for that nice summary. So if I can just summarize this one slide, I would say that the point I kind of wanted to hit here was impact of smoking. So if I can summarize what I heard between lines, you guys don't treat smokers differently, or people with heavy smoking history that are HPV positive, P16 positive, differently than those that are non-smokers. Is that correct?
Yeah, we the only difference that we would have is the way we counsel them in terms of their expectations of chances of cure. And then of course their fitness for de-escalation depends on the trial.
We did stratify by smoking. I could just comment, and it made no difference in 3311.
Perfect. I was going to ask that, Bob. Perfect.
So in 1273, our phase 2, we only allowed patients with less than 10 pack year smoking, and we've seen the good results from that. 1675 did allow smokers as well. Like Bob, we stratified for smoking. I'm not allowed to discuss what those results are yet, but we don't routinely look at smoking right now in a clinical setting without something unusual in pathology that we see.
Okay, we'll take that as a nudge, nudge, wink, wink.
That's right.
Next slide, please. Here is this patient did have surgery, and also here's the pathology: squamous cell carcinoma, 1.9 centimeters, P16 diffusely positive as previously described. All margins are negative. Closest margin was a deep margin, which was 0.5 centimeters. So what we felt was a good cuff. Neck dissection was a good neck dissection with 35 nodes, and the synoptic was T1 and 0. So on this point, I just wanted to ask the panelists, in the neck dissections that are performed, I'm sure you guys must get referrals from other centers, or even sometimes an internal case where you don't have a high yield of nodes. Maybe you get less nodes than you had anticipated. Do you have a cutoff where you say, gosh, I'm not happy with this particular report as treating oncologists? Maybe we'll start from the bottom up, Dr. Palma.
Yeah, we like it to be 18, right? And sometimes we'll wish maybe the pathologist had even looked for a few more if we get 16 or 14. The unknown, though, in a patient, let's say this was 0 out of 15 nodes. The unknown would be, do you go back and do something else? And our approach has been, if we think it's been an oncologic dissection by an oncologic surgeon, we would not go back. And we would not, in this case, if that was the only thing we were worried about, because everything else looks pretty pristine here, we would not give any radiation for that specific reason.
Got it. And Dr. Ferris, I know that ECOG 3311 sort of had some criteria about the nodes being quantified. So is there any preliminary sense of whether that really plays out?
As long as I'm not taking Dr. Meyer's slot, we've been crowding her out, and I want to make sure she can comment. It's true on 3311, we had less than 20 as a minor protocol deviation, less than 15 as a major protocol deviation. That was relatively uncommon, the less than 15. We had a maybe 5 to 8% between 15 and 20, but I completely agree with Dr. Palma. The data from Vasudevi and some data from Chris Holsinger suggests from RTOG trials, 9501 and others, that 18 is an adequate sampling.
And Dr. Ma, anything additional to add?
No, I wouldn't add anything additional. I think those are great points.
Okay. And Dr. Meyer, I did want to ask you, since you are treating medical oncologists in the panel, when you see these patients coming back to your clinic, how much stock do you place in this nodal yield?
Oh, no, clearly it's important. And this is, a very reassuring pathology report. And, a lot of times I may see this patient in multi-D clinic before treatment and I don't see them after. And so it's not, a matter of being crowded out, but, for this patient, fortunately, there's no role for systemic therapy.
So next slide, please. And I think we have, I think we all agreed with this at this point in time. Next slide. And so once again, a poll, please, for the audience. And thank you all for the chats. I will get to it, I promise. I'm trying to check on it. Dr. Brody, we're getting to your question in a couple of cases down the road. I will hold the panelists to that.
And maybe while the audience is answering, I wouldn't mind hearing from Dr. Ferris, because there are some radiation oncology residents on the line as well. If we do get a situation where we have, let's say, 14 nodes recovered, let's say it's an outside surgeon who you've never met, would you think that it was an issue with the pathologist looking through the sample? Would you think it's an issue with the extent of dissection, maybe leaving off 2B? What are your thoughts about that?
It's a tough situation. It can be both. Every surgeon who talks to the family after a neck dissection gets asked, how many nodes did you take out, doc? And we always have to say, embarrassingly, I don't know, because we rely on our pathologist to find them. So it's certainly both, and expertise exists in high volume centers for both surgeons, pathologists, as it does for radiation medical oncologists. So I completely agree with you. It's a conundrum. And I think you do have to put adjuvant, hopefully not high dose RT, but some sort of adjuvant therapy on the table. A post-op scan, which often our radiation oncologists do, might give you a sense of undissected areas that should have been included.
Mm-hmm. Thank you.
So
I see I didn't win anybody over in that poll. When the Radonc numbers went down, I need to campaign a little bit better.
the campaign those Radonc residents. Okay, so we'll stop.
Yeah, I do want to add for the option of definitive chemoradiation. I think I probably would have also selected either TORS with pathology-based adjuvant or consideration of radiation alone. But for a patient with no nodal disease and a fairly small size primary tumor, I would not plan to give cisplatin to that patient.
Perfect. Again, I wanted to start off with the next slide, please. I wanted to start off with a case that was favorable to the surgeons. Get our morale up as we go through this process. So here's an alternative scenario, though, and so this is something that I think is a case that I came across just recently. Biopsy reveals P16 with some focal staining, but less than 5% of cells. So there's some staining, but it's not diffusely positive as you would expect for a true P16 positive tumor. But the high-risk HPV subtype in situ hybridization is diffusely positive. So P16 negative, but in situ, there is HPV RNA present. Would this change your management? Would this change your counseling of the patient? And I use the word "quote unquote" stage, since P16 positivity is what we define oropharyngeal cancer staging by. So clearly, it does change that stage. It's a bit of a rhetorical question, but let's start from the top down. Dr. Meyer, I wanted your opinion on this too, because I think this is a bit of an unusual and vexing problem.
This is an unusual and vexing problem. So, Amanda Seary years ago had looked at an analysis of different subtypes of oropharynx cancer and looked at direct HPV testing, P16, and then had also looked at the survival. And in her analysis, the group of patients who had the favorable survival were the ones who were P16 positive, as opposed to P16 negative, even if there was evidence of HPV. And so I think for an oropharynx primary site, I tend to use the P16 as the prognostic biomarker in this setting. And we don't really, we'd have to appreciate the difference between oncogenic versus non-oncogenic infection.
Okay, so just to be clear, that was a high risk, so type 16 and 18 subtype in situ was what was performed. So Dr. Ma, would you have a...
Yeah, so I just mirror what was just said as well, because first of all, the major trials looking at de-escalation and also looking at the application of HPV status had used P16 as the marker. And we also know that P16 overexpression is intimately tied with the oncogenesis through HPV for these types of tumors. So having less than 5% staining with focal P16 makes me a little worried that we're looking at some type of contaminant infection event, or we're looking at some type of HPV integration event that is not transferring what we would standardly think as HPV biology.
Fair enough. Dr. Faris, Dr. Palma, I wanted to open it up to you for you guys, unless you have something that you differ in opinion on what's been said. So it sounds like P16 sort of trumps the HPV in situ hybridization.
Yeah, it feels like it's a little bit of an academic point, because I think if this patient is resectable, it wouldn't change management. We would do the same thing. It may come back to whether you add adjuvant therapy if you think it's an HPV negative cancer, and we tend to try to intensify for that disease, but that's off trial. I don't have any data really for that.
And I just make the point that even if it was frankly P16 negative, we don't tend to change our choice of first line treatment because of the P16 status.
Right. Yes, this
Really,
is a bit of an academic point. I'm sorry. Dan.
it does fall into what to do with de-escalation afterwards, like was discussed. I think the more common scenario you'll see is the P16 positive HPV-ish negative cases, and those are cases that we don't infrequently see. Bisham Chera, somebody asked a question about circulating tumor DNA. Bisham Chera, when he was looking at his circulating tumor DNA data for his P16 positive HPV negative patients, there was a proportion of those patients that did not have detectable circulating HPV-16 DNA. And one of those patients, two of those patients, in fact, were found to be P16 positive by virtue of P53 mutation rather than actually HPV infection. So those are the ones I really, really keep an eye out on for in the setting of de-escalation.
Right. Excellent. Well, let's move on to in the interest of time, we have a couple of cases that are really good. So this is Dr. Meyer's case. So I'll hand the podium over to her.
Okay, so this is a case of a 57-year-old man who has a history of tobacco smoking, one pack of cigarettes per day for close to 30 years, who presented with a painless left neck mass. His initial imaging was a CT of the neck, which showed a 2.8 by 2.5 centimeter cystic appearing mass with on the left side of the neck. And an FNA was done initially, which was inconclusive. And then he presented to our center at that point. He underwent an endoscopic evaluation in the OR. The biopsy of the neck was positive, and so he subsequently had neck dissection and had interrogation for the primary site and was found to have base of tongue cancer. His ultimate surgical plan and treatment was hemiglossectomy, partial pharyngectomy, and the neck dissection. The pathology showed an invasive squamous cell carcinoma, moderately differentiated with basaloid features, 2 centimeters in greatest dimension, was P16 positive. The margins were free of cancer. And on the neck dissection, 2 out of 16 lymph nodes were positive for squamous cell cancer, but there was no extranodal extension. Next slide. So this is the final diagnosis, and the initial treatment was, as I mentioned, TORS. So the question and discussion at this point is, what is the adjuvant options that we would want to consider at this time? So I think in the interest of time, so we can get to the discussion, we can just move on to the polling.
Ronnie, while we're waiting, do you have a distance of the deep margin in the base of tongue? I didn't see the distance of the margin.
And
it maybe,
I would,
was it incidental?
I think we can, I have to admit, I can't remember off the top of my head, but for the sake of the discussion, I think we can, you know, assign a value that we, you know, as we're discussing it.
Fair enough.
And I think, yeah. So let me.
You guys see the poll?
Can you see the?
Okay, I hope the audience can see
So,
the poll as well.
Okay.
It was up for a minute,
about,
and then yeah.
Okay.
Let's see. Well, I'll say the results. So 24% observation, 9% cisplatin and radiation to a dose of 66 gray, 42% IMRT 50 gray, and 24% IMRT 60 gray. So we have a little bit of a spread. So for our panelists, okay, attendees can now view it as well. Yeah. And let's say, you know, that the margins were clearly negative for the sake of the discussion. So I'm going to go from top to bottom on my top to bottom on my panel as I see it. So, Dr. Ma, what are some of the considerations you would take into account when deciding adjuvant treatment?
So, you know, let's talk. This is the classic case of a patient that only has intermediate risk factors after surgery, defined as what would traditionally have been called N2B disease, right, in the AJCC7 staging. You know, oftentimes we're asked, can we just observe these patients? And, you know, we did a joint analysis, Mayo and Penn, looking at our patients who declined adjuvant treatment with intermediate risk disease, and their risk of local regional failure at 2 years was 12%, with about 1 in 4 of those patients who had local regional failure having either declined salvage or having unsalvageable disease afterwards. So even though I would agree that the risk of local regional failure for these intermediate risk patients is a lot lower, for HPV positive disease, it still mirrors what we would expect the standard failure rate for patients with intermediate risk disease would be. So we would offer adjuvant treatment afterwards. What kind of adjuvant treatment to offer afterwards is also something I see there's a lot of spread in the poll. I see that IMRT to 30 gray with docetaxel was not an option up there, but you know, at our institution, that would be something that we discuss with the patient. The whole de-escalation question we can maybe table for a little bit later, just because I suspect there'll be a longer discussion. But strictly on the observation versus adjuvant treatment question, I do think this patient should be, you know, they can be counseled concerning observation, but we would be leaning towards adjuvant treatment.
If I may interject, I would love to jump into it in the interest of time, because, you know, we have until 8:30, but I think this is the meat of the matter, you know, is what are we comfortable with as a field in terms of de-escalation, you know, and to your point, Dr. Ma, you said at Mayo, you'd be willing to use your phase 2 data with OC and 30. And so, you know, where does that come in? And so I'm sorry, Dr. Meyer, to jump in, but I wanted to push forward on that. So Dr. Palma, how do you feel about a lot of the audience jumping on the 50 gray?
Yeah, I think it's completely reasonable, actually. I think we can take a step back and say, what do we need to prove in order to de-escalate or to escalate in oncology? And generally in the head and neck world, escalation has happened for an overall survival benefit. If you look at the addition of, ECE positive margins, although it was a post hoc analysis of 2 RCTs unplanned, it was OS, and that's where that came from. So I kind of feel like if you're going to de-escalate, but you're preserving OS, you're probably safe. Do we need a phase 3 trial, a non-inferiority for everything we do? That would be the way to prove it. Dr. Ferris could just have randomized another 900 patients and we'd have the answer, right? But we're not going to have that. So there has to be some practicality. And in some cases, phase 2 trials can change practice, especially when it's highly plausible. Is it plausible that 50 gray is going to be just as good as 60 gray? Extremely plausible. Of course it is, right? And so the way I would counsel my patients is that it looks like 5 weeks is just as good as 6 weeks. And that's what I would say. I would say if you really want to make sure we do everything possible, I'll give you the extra week. But my preference would be to do the 5 weeks. And then at our center, we wouldn't be using cisplatin. 66 is a bit warm anyway, even with other cisplatin. So I was in the red group on this one.
And then there's a question in the chat about the radiation field, whether it would include bilateral necks and low dose to the contralateral neck. We actually at our institution have a trial ongoing now, de-escalating the contralateral neck. So this is something that we discuss a lot.
Yeah, for base of tongue tumors, we would standardly treat the contralateral neck. If we're going to standard radiation doses, we would go to a lower dose to the undissected neck. WashU has data for the dissected contralateral N0 neck of omitting radiation to that altogether. When we talk about de-escalation, sometimes we omit talking about volume de-escalation as well, right? Omitting radiation from the contralateral side in the presence of contralateral PN0 nodes, or omitting radiation to the primary site. But that's worthy of consideration. If you don't mind me for 1 second, Bob, I thought I'd talk about de-escalation off trial point for a little bit, because I think it's a fairly controversial point, and I think it's very rightly a controversial point. I think us radiation oncologists sometimes are a little burned by the cetuximab data in reference with HPV, and we worry about repeating such data in this setting. So I'm just going to talk about in the setting of high surgical volume centers that have intermediate risk patients such as this. We have data from 3311. We have the 2 and now 5-year data from 1273, which will be presented at ASTRO. We have the phase 3 data that will be coming out from 1675, which I can't talk about, but I'm something that we as an institution, after careful consenting, are offering patients. So the question becomes, what is our standard, right? When do we as a field feel that it will be necessary to, because if the standard is going to be a true non-inferiority trial, we ran the stats for 1675 to see what we needed for a 2% non-inferiority, and it was 2,000 patients per arm, right? That's not going to get done in any setting. We have longer phase data, 5-year data now for 1273. We have ECOG 3311 data. What is the point that we will be comfortable as a field saying de-escalation is appropriate? So I think that's a question that, if your answer is after we have a non-inferiority phase 3, that's a reasonable scientific answer, but understand that what you're really also saying is we as an institution will never be comfortable de-escalating in an adjuvant setting because that data is not forthcoming.
So about a quarter of the people who in the poll did say observation, which is of course the ultimate de-escalation. So does anyone want to speak to that? And I think this may go into Dr. Devari's point in the beginning a little bit about how the numbers and the staging from AJCC 7 to 8 has maybe influenced our outlook on how we're thinking about it. And instead of historically how we would think about it with number of nodes with AJCC 7.
Yeah, so on the observation comment, and just to build on what Daniel said a little bit earlier, I think the skeleton in the closet in radiation oncology I was talking about some of the surgical skeletons. Now I'll talk about our skeletons. The skeletons for radiation oncology is our volumes are not overly highly informed, right? And they're sort of passed down from era to era. You know, omitting the contralateral neck, probably doable for a lot of base of tongue cases, but we don't, right? Even a lot of centers, a tonsil with one node will treat the other neck. There was a study by Paul Harari's group where they sent one tonsillar plan to 20 different centers to see how it was contoured. And it's like, there were no two the same in the contours. There were no two the same in the doses. And the problem with that from our point of view in radiation oncology is you can't really have incremental improvements when everyone's doing something different, because you can't really see what the deviation is when you want to make one systematic change. And even running trials, you know, the main objection we had to Orator and Orator 2 is that's not how we do it in the radiation oncology world. But that's because nobody does it the same, right? So our volumes aren't all that well informed. I think in some select cases, we don't do it, but we should be investigating leaving off the contralateral neck. We are running an RCT on that. It's open in some US centers called PRESERVE, but it's mostly oral cavity, not so much oropharynx. And then in terms of observation here, you know, it would be nice to get more data. The data that Daniel alluded to, you know, that's still below the 20% that we used to quote as the reason for radiating. So I think you do have a compelling argument. And I think that is a really good area for future study. The way I think that we win with our P16 positive patients is if we can get them one modality. I think that's a win-win-win, regardless of whether it's either of the two local modalities. So getting more people into that observation group, I think would be fantastic.
If I may ask a
Dr.
question.
Ferris, I was going to say, we haven't heard from Dr. Ferris about this.
That's kind of unusual.
Question. I think I know what you're going to say.
Well, I was actually going to just twist it around a little bit because, you know, this was a surgical case, but Dr. Palma just mentioned something that stimulated a thought in my mind that he's right. Single modality is great, but if you went with an RT alone, is HNO02 convince you to go to 60? Or is it 70?
That is a really, really good question. So as a specialty, we've decided no, right? Phase 2, we're doing the non-inferiority, but it's really, really compelling data. Even Dr. Meyer mentioned this earlier, even the arm that lost HN002 is highly compelling. You know, the way that was run was there was a historical bound of 84%, and you had to have a p-value showing difference from that 84%. So one arm did, one arm didn't. But the difference between the arms, it wasn't a head-to-head trial, was only 3% in PFS and 0 in OS. So I've been harping on Sue Yam about the fact that maybe the other arm should have been chosen. And lo and behold, in the phase 3 non-inferiority, it's high dose cis.
Yeah.
So the way that we've taken, you know, I think you can argue the HN2 data in a lot of different ways. The way that we've taken it is if a patient bails out in the last week, we're pretty comfortable with that. But other than that, we're still going, and I'd be interested to hear what you guys are doing. Is anybody adopting, in the patients who aren't going for surgery, is anybody adopting the HN2 arm as one of the two arms as their standard?
We're not, and I just not just yet, and partly because there's already a planned follow-on trial, so we prefer to accrue to that trial and revalidate it. Whereas I think 3311, the hope is to randomize it to a non-surgical regimen, as opposed to kind of revalidating one of the 50 versus 60 arms for the reason you pointed out of what it would take. I wanted to come back. Dr. Palma's description was so essentially exactly what I would have answered. And then the last couple sentences where he potentially offered the patient, if they wanted to go to 60, to quote unquote, do everything they could, then why not go to 70 to 80? I mean, if no data can show you that 60 is better than 50, why give the patient the option to just blast the constrictors?
Well, no, that's a very, very good point. And when you phrase it like blasting the constrictors, it doesn't sound great. My point was more around, do we change practice on a phase 2, right? And I have some other phase 2 in other parts of medicine that people debate about whether or not, you know, in the oligometastatic stage, should a phase 2 change practice? And that was more a nod to the purists around not changing practice in a phase 2, but I'm fully supportive based on the evidence of, I think that 50 gray is probably adequate, especially when we're talking about observations. So 0 gray as being adequate.
We did, as people have noted, have a lot of real world data, which is a nice way of saying patients got assigned to an arm and then all of a sudden didn't feel so comfortable. And some people didn't like the thought of 50. And they said, as Dr. Palma mentioned, some patients say, oh, I want to do everything I can. I had some patients, I remember one, the wife was a physician and she said, no, pulled him off the trial and added cetuximab. So, and then others who went on the trial hoping to get de-intensified, got randomized to 60 and were disappointed and pulled off. So, we've been dinged a little bit for some of that, as we euphemistically call it, real world data. But the patient does have a role to play in this. I just want to state that I don't think the data support at present observing a patient with 2 nodes. I think that needs to be tested.
And is it okay if I build off that comment? Am I going to put us over time? I think one thing that has really struck me over the years is that we have a disadvantage in surgical and radiation trials because we don't have a placebo control, right? And it's not because I think placebo is going to affect overall survival or probably not even swallowing function, but it's the blinding of the patient and physician and how, as Dr. Ferris said, people react. So if I was a medical oncologist, I'm very jealous of this. If I'm testing a new drug, nobody knows what anybody's getting and everybody's happy, right? And then when someone progresses, you move on. But with many of our radiation trials, surgical trials, people enter the trial because they want something. Like for Orator, you had a 50-50 chance of getting randomized to TORS or to disappointment because they only went on the trial if they wanted the TORS, right? If they didn't want the TORS, they weren't on trial. Same thing with Orator 2, right? And our oligometastatic stereotactic studies, when people get randomized to something they don't want, they're not happy. And so I think that I just ask our medical oncologists to be a little bit nicer in terms of the fact that we do have these post-randomization things we can't control. In Orator, one of the patients left to the US and paid for TORS, right? On the radiation arm. That's not in our control, right? So we do the best we can, but we can't achieve the level of perfection of these placebo-controlled drug trials.
So can I hold the panelists now a little bit, hold your feet to the fire? Do we have equipoise to move away from the Fletcherian model of the tongue base being a midline organ that drains to both necks, and the concept that radiation oncologists still feel really compelled by history, by dogma, so to speak, to treat bilateral neck? And do you think there's equipoise to actually do this as a trial in the context of future trends?
Can I jump on that? Is that okay? The thing I find about these equipoise questions is that someone could just come in and say, I don't have equipoise. I just think this is better. I just think that is better. I think there probably is community equipoise. And even if there's not, I think one thing I would say to the residents is that if you can do little trials that challenge dogma, not everybody can have a 300 patient surgical randomized trial, but you can do little trials that can have some type of an impact. So is there a trial you could design, whether 1 arm or 2 arms, that would test that? And I think, pretty much everything in medicine should be up for discussion, because in 30 years, on this webinar with all our children, and we're all retired, they're going to be questioning, what the heck? They were talking about TORS and radiation. That's so old school. How did they even consider that ethical? Things are going to change. And I think it's often our residents who will be able to change the paradigm because they come in with a fresh view of things.
And somebody, when we're discussing adjuvant treatment as well, let's face it, we as radiation oncologists, we're guessing, right? It's when we're talking about a treatment where, at best in the data that I cited, about 1 out of 6 patients would have a benefit with adjuvant treatment. That means 5 out of 6 patients will not have a benefit with adjuvant treatment. We need to, even before talking about are we going to treat the contralateral neck, we need better individualized medicine means of determining whether the patient even needs adjuvant treatment outside the realm of there's these pathologic risk factors that might suggest that there's the presence of micrometastatic disease. Somebody brought up the question in the chat about would circulating tumor DNA be useful in this respect? Maybe. We'd love to find out. We're in the midst of trying to test that question. So I think the next step beyond that would be individualizing adjuvant treatment, not just in the setting of reducing radiation dose, but personalizing risk based upon biologic factors after treatment.
So it's 8:15. So in the interest of time, I think we could move on. Should we do this polling question one more time? to see where everyone landed. And let's maybe defer on this discussion for now about smoking since we discussed it previously, but can you put up the poll again? Can everyone see that? So if, I'm not sure if you're all seeing that or not, but now the results are 23% observation, 0 for cisplatin and 66 gray, 61% for 50 gray, and 16% for 60 gray. So interesting. We didn't change any minds on observation, it sounds like, but there was definitely a shift to 50 gray after that discussion. So I think probably we can just go on to the next case now.
Let's go to the next case. Next slide. I can close this one. All right. So this is was this one mine or yours, Dr. Mara? I can't remember.
I think this is mine. So I'll start with this one. So then this is a 58-year-old gentleman who is a non-smoker who presented with a neck mass that was growing over about 4 months. He saw his local ENT who noted a left tonsil mass and did a biopsy which showed a P16 positive squamous cell cancer. When he presented to our center, he also already had the PET CT, which demonstrated a focal intense hypermetabolism in the left tonsillar region, consistent with the known malignancy. And there was intense uptake in 3 separate nodes in the left neck, including 2 left level 2A nodes and 1 left level 2B node. Next slide, please. So the pathology, so he, to be consistent with our today, underwent TORS, radical tonsillectomy, partial glassectomy, and pharyngeoplasty with left selective neck dissection. Tumor size was 2.1 centimeters, and 8 out of 19 lymph nodes were identified. There was, of the nodal disease, the largest metastatic deposit was 2.1 centimeters, and extranodal extension greater than 0.2 centimeters was present. Next slide. So what would be the adjuvant treatment for this patient? I think answers are still coming in. There's a comment in the chat about showing the pathology slides, which I don't know if we can do that, but essentially 2 centimeter primary with multiple, oh, thank you, okay. So looks like most have responded. So sharing the results, 70% selected weekly cisplatin with 66 gray, 15% bolus cisplatin with radiation therapy, and then 15% was radiation alone for this P16 positive squamous cell cancer in a non-smoker. So to start off on our discussion, any initial thoughts on the approach? What is the degree of extranodal extension, if we can say, that you believe is relevant in your practices when deciding the adjuvant therapy for this population? So Dr. Palmer?
Yeah, so thanks. That's great case. I was talking earlier about skeletons for radiation and skeletons for surgery, and so now just to be equal opportunity, there is this big skeleton in the medical oncology community around the exact indications for chemo and what is a sufficient improvement that we see, right? If you say that PFS is a is a good enough indication, then, which is a fair argument, then you can be giving it for a lot of things, because both of the post-op trials were positive for PFS. So you could be giving chemorads for LVI only, or multiple positive nodes, right? And then if you take the margin positive ECE as an indication, then as I alluded to before, that's a post hoc analysis, unplanned, of 2 randomized trials. And if we tried to bring that in as a standard now, I think we'd get pilloried for that. But history is history. And so we do treat based on those 2 factors, as I've just elaborated upon. ENE in the HPV positive setting is a bad prognostic factor. We know that. Can we modify that, right? It's a prognostic factor. Is it a predictive factor as well? We don't really know. HPV related cancers are highly chemosensitive, but it's definitely an open question. So our practice has been that ENE, we provide concurrent chemoradiation, and that gets them, in this case, it would buy them trimodality, which is probably not the best situation in the world.
Maybe I can comment. First of all, I think extremely well articulated. I agree with all of that, but this is actually a bad tumor. Yeah. There's 8 nodes positive. There's greater than 2 millimeter ENE. I'm sure the surgeon thought she got this all out, but the tumor is within 2 millimeters. This is a bad one. And what you look at, 3311, when I got these patients, my heart sank. But later I began to think, we're learning biology. And so I think we need to understand that 3 modalities in this case still only gets you 90% PFS, which is obviously outstanding, but we need to keep following those patients, and it may drift down with some distant disease. So this particular subset, I think we need to study biologically. And we have a sorry.
I was going to say we finish and then I'll go.
I was just going to make the point that we would try to select the patient out with some preoperative imaging or genomic signatures, as we and others are trying to do. It sounds like some folks on this webinar. So I don't want to filibuster. Go ahead.
Well, no, I was just going to add to that, even though I don't think any of us are happy whenever we have an outcome where we're doing treatment with all 3 modalities for these patients, but we do learn a lot about the potential prognosis from the pathology. And so, just to kind of reiterate, like if the patient had just received definitive, radiation, I don't know if it would have changed the outcome, but we wouldn't have appreciated, the potential risk this patient would have. And that's something we can use as a jumping point to study future questions of then what to do next when we see a pathology report like this.
That's a really good point. One other little interesting fact about HN2 that we talked about earlier is that you could have ECE and go on that trial. I don't recall this specific patient's smoking history, but if it was less than 10 pack years, they could have been on HN2 because there are even guidelines on how to contour the areas of ECE, and they would have been randomized to 60 gray and 25 alone. I'm not saying that's a reason to do that. I wouldn't do that in this case, knowing what you know now, but it could be that the ECE is not as important as we thought, and maybe trimodality isn't important. If there were some patients like this on HN2, they obviously, if there was a substantial number, then they obviously did well, but we don't know that.
In this specific instance, though, that would have been difficult to see, right? This patient came in imaging with 3 nodes that were apparent on PET-CT, and we found out about 8 of 19 nodes on the post-op pathology. So it's again, towards your point, we don't know in HN002 whether those patients were included or not. But I would echo what Bob said. This is a nasty tumor one way or the other. At Astro Head and Neck right before COVID hit, we presented our 1273 data in comparison kind of with a matched cohort of standard controls from the 60 gray arm, just because 1675 data wasn't available yet. And these patients, the ones with 5 or more lymph nodes involved, whether you got standard of care or de-escalation, your rate of distant metastases at 2 years was 40%. So these patients are at very high risk. There's the potential of biologic selection to, we always talk about de-escalation. Of course, de-escalation is close to my heart, but these patients need to be considered in protocol setting for some type of systemic intensification afterwards. At least that's my thought on the matter.
If I may ask the audience, in the interest of time, we don't have too much time to maybe go through an entire other case, but two questions. One is, assume that there was no E&E and just 8 out of 19 nodes involved. Would you give a chemo? That's a question from chat. Part two of that question is, let's hypothetically assume that this was only 3 nodes, no E&E, but the margin is 2 millimeters, right? I wanted to go into that margin question. How much of a margin are you happy with? So let's start with the second. Let's start with the first question, which is, without E&E, would you use CIS? Which is from the chat.
I would just say 75% of 3311 got into that arm D based on E&E greater than 1 millimeter. So it's pretty unusual to have, 5+ nodes without substantial E&E, and those two just biologically go together. I was kind of interested that nobody has, Ronnie's probably just dangling it to give us a hard time about the bolus CIS versus weekly CIS, which didn't really come out in the voting. We have a trial, Azuma knows, that we've now completed a small 42 patient where we added nivolumab instead of CIS, because I'm not so convinced. I think this patient with many nodes and gross E&E is at risk for distant disease, and I'm not sure CIS really treats that. So maybe immunotherapy will help, but maybe answered a few questions at once there.
Yeah, I agree. I think we still, the ongoing or future NRG study will perhaps answer the question, but it still is, even in 2021, we still discuss cisplatin dosing.
So what about the question about margins? How much of a margin is good enough for you guys?
We use any clear margin. We don't have any definition of what is a minimum margin to be considered clear. Again, this goes back to kind of what the relationship that you have with your pathologist in the intraoperative setting would be, the familiarity of your surgeon with the TORS system. Particularly, somebody asked about deep margins, posterior margins before, particularly in the setting of tonsil tumors. If you're going to require a 5 millimeter posterior margin for a tonsil tumor, you're going into the carotid artery at that point, right? That's just not physically possible to obtain. So if you have good intraoperative pathology, if you trust your pathologists in the case, and then the second thing that needs to be clarified, are we talking about fresh margin, frozen margin, or after FFPE? Because this shrinks, right? This could have been a 5-6 millimeter margin that shrank down to 2 millimeters if you're looking at in a FFPE setting. So we don't particularly use margins, but we have very close collaborations with our pathologists.
I'm gonna say, spoken like a true surgeon. Dr. Palma, anything to add?
Yeah, no, nothing particularly to add. I think that was an excellent answer, Daniel. We do the same thing. If the margin is not touching, then it's not positive, and then we use close up until 3 millimeters. But that doesn't buy the chemo at our center. In terms of the nodes, as I mentioned before, generally we're not giving for a number of positive nodes. Although we do have situations where a med-onc will see a pathology report and say, I feel that this is a risky scenario, and we'll add it.
Yeah, no, I agree. I'm usually, that may be a scenario where I end up having a discussion with the patient, but most of the time we don't proceed with it, given, especially for an HPV positive, the lack of data to support it. But I think I agree with Dr. Ferris' statement that normally if there are this number of lymph nodes, we would have seen extra capsular extension anyway.
And then one other question. Can I ask one other question?
I think we're looking at the same question, yeah.
To everyone. So, Dr. Ma, you brought up this point of distant metastasis being a bit more common in this group, not a bit, but a lot more common. Dr. Ferris said the same thing. However, when we look at the survival curves that are available, they look spectacular, right? Not what you'd expect for a 40% DM rate. So the question to the panelists is, does this then mean that those patients are salvageable? And Dr. Brody from Penn asked a question: how do you surveil patients for distant metastasis in this scenario? What's your protocol? And two, if they do develop it, do we how do you treat them? and we can kill two birds with one stone.
I'm going to be a little bit, maybe I'm going to say something that makes me a little bit of a black dog here, but we aggressively surveil these patients, particularly these patients with 8 nodes, because we feel that there is interventions that are feasible for bending their survival trajectory. We'll get PET scans at 3 months, 1 year, and 2 years for these patients, with CT chest kind of in between as indicated by clinical symptoms. When we have oligometastatic disease, whether it be like a single lung node or lung nodule or solitary liver met, we'll treat those aggressively with SBRT or surgical resection. My follow-up day is, just had my follow-up day. I saw a couple of patients then, once for his 2-year follow-up, once for his 5-year follow-up after a SBRT to liver nodule. Lung nodule for HPV positive oropharynx cancer. So, I think this is a different biology than what we standardly see with metastatic disease. We've obviously all seen those patients that have had HPV metastatic disease that kind of blew up and went everywhere very quickly. But I would say there's a sizable proportion of patients that have long-term survival. And I think the Cleveland Clinic published some of their data on that, long-term survival after metastatic disease in the setting of HPV positive disease.
And is anyone using the circulating tumor DNA as surveillance, especially for high-risk patients?
No, we are not up here, not up in Canada. Robert and Daniel are using it in the US?
Just investigational.
I'm sorry, which surveillance modality, please?
Like the circulating tumor DNA, ctDNA.
We've used it very sporadically. There's not a clear clinical workflow for us to do so, but we are looking at it in an investigational basis. And to the point about insurance approval, yes, getting those additional PETs is a pain to approve.
Should we go on to the next slide? I don't know if there are other, maybe there's another polling question. No, I don't think so. So we're at 8:30, which is sort of our scheduled end time. So I think in the interest of time and keeping everybody, being respectful of everyone's time, thank you to our panelists for their wonderful comments. I hope that this was informative to our audience. I'm excited that we have 70 people still with us after an hour and a half of talking, so that's great. I really wanted to thank the Head and Neck Society and the staff, particularly Nicole, Christine, Carey, who've been wonderful to work with, helping us put this all together. And of course, the generous support of Intuitive Surgical, which has allowed us to have these webinars and open them up for everybody. So any other final comments from the panelists or Dr. Mehra before we sign off?
No, just I agree, concur, and thank everyone for staying with us the whole time on our evening.
It's wonderful to see a multidisciplinary panel where we can have some ideas of future directions and hopefully where things are going, such as biomarker driven de-escalation or maybe biomarker based prognostication and predictive markers. As you point out, Dr. Palma, E&E might very well be a negative predictor of outcome, but can it be modified? Is it something modifiable? Is there anything that we can do to change it or not? It is a question that remains to be answered. So thank you to everyone, and have a great rest of the evening and rest of the week.
Thanks, everybody. Bye-bye.
Thanks.